let's get started. So I just want to introduce Sherman, who's here today with us to talk about healthcare and working on healthcare. Sherman, you have such a wide variety of things in your background, working
Mhm.
on the actual clinician side, working with clinicians to develop projects, working with VC to help fund projects, thinking about all the different areas of healthcare. So we're excited to see you come in as a potential mentor for folks in this program because
Mhm.
it's like you've seen it from all sides. I feel like, especially around tech and areas that really matter to people like healthcare, you don't want to go too far on the tech only side without that domain experience, thinking
Mhm.
about people and patients and people who
Yes.
have been in healthcare for a long time often just haven't been exposed to what new tools can do, like what different tools or processes might help people. And I know that you've also been really concerned, like it's important to you to think about underserved populations, efficiency, equitability,
Right.
making things equitable. And I think people in this program really care about a lot of that same stuff. So
That's
a lot of good
awesome.
alignment. And so I want to just like offer it to you to share a little bit more about your background, introduce yourself. I'm going to hand it to you.
Sure. Hey, everyone. Well, great to have so much interest in healthcare. I think it's a really needed space. I'll add to the intro that Kathy had shared as I kind of go into my slides here. Kathy, is this showing up okay for everyone? Let me just kind of load it up here. Can you guys all see this? Okay, great. So yeah, like Kathy mentioned, I am actually a computer science major by background. I was, formerly a hacker, just like many of you, very much a tinkerer at heart. So I was trained in engineering. I went to Stanford for computer science. Ended up working actually at Khan Academy. I had my first passion was ed tech, so which is why I'm really excited to see this particular fellowship come to life. I launched the first version of Khan Academy's Android app and then found my way into healthcare for a variety of reasons. But one, just really drawn actually as a pre-med initially in college to kind of the physiology of health, and then also kind of helping patients at scale with technology. And then, like Kathy mentioned, I've taken a couple of detours into venture capital, so learning a lot how to build companies, scale ideas, from a business perspective, ultimately to serve patients and improve access to healthcare. And now I work as an emergency doctor at Stanford. I see patients honestly on their worst days. And I think it's a real privilege to be able to meet folks at that moment in time and to help them get the help that they need. And I feel, yeah, really grateful to have this job where basically I leave every clinical shift knowing that I directly help people. And I can also work on some of these issues of access, equity, efficiency at scale with my other kind of hats on. So yeah, I'll give a kind of a brief overview of how I see the world of healthcare as a physician and also as kind of a investor innovator in the space. I'm glad to see a lot of the ideas actually that you've put in the chat already. We'll talk through how to sharpen sort of those ideas, how to give you guys a little bit more data to kind of run at those, and ultimately, if you want to scale those outside of this particular summer, what you would have to do to kind of see those ideas all the way through. Okay. But maybe by a show of hands, you're welcome to use the emoji sort of Zoom interface. Who's like been to a doctor in the last like 6 months? I'm curious if anybody's like seen a doctor. Okay, great. So McKinley mentioned who's been inside a hospital? Hospital meaning like you're not in a doctor's office, but like actually in maybe with maybe a hand emoji, like actually like in a hospital. And hospital in my world usually requires an admission, but sometimes you're just seeing an emergency doctor like myself, and that might be a little bit more serious of a healthcare issue. So we'll talk about all those differences, and then also kind of the underlying stakeholders behind these. So every time you see a doctor, you may be paying a copay, you may be using your insurance, for example. We'll talk about why that adds certain complexities in healthcare. But my job is really just give you a crash course overview of why healthcare operates in our country the way it does, some of the inefficiencies that I see as a physician and also an investor, and maybe land on a couple of general themes that we can talk about at the end. Okay. But yeah, to just get you guys familiar with the healthcare world that maybe we all live in, let's start with this particular patient, maybe like some of you. This is actually, Maya, seemingly a college sophomore, she's still actually on her parents' insurance. She sees her primary care doctor for this kind of persistent rash. At the end of the visits, the primary care doctor says, I'm not really sure what to do with this rash. Let's refer you to a dermatologist, a skin doctor who's a specialist in that area. Okay. That usually takes actually a couple months to get an appointment. Has to come usually through a generalist, like a primary care physician. It's really hard these days to go directly to a dermatologist, but that is possible in some cases. At the end of her primary care visit, actually, ends up owing about $30. It's called a copay. But her parents' insurance is actually taking care of a lot of the visit. It's usually a couple hundreds of dollars to see even just a primary care doctor. You get some basic labs drawn, a physical exam, but that ends up being, at least for Maya, just $30 at the door, which is great. Um, to get to a dermatologist, there's something that happens in the background called a prior authorization. And so, for you to be eligible to see a dermatologist, your insurance technically has to approve it. Most things that come from a primary care doctor after you see one is approved automatically because if they trust the primary care doctor knows what they're doing and it's outside of their scope, then the dermatologist should be a logical kind of next step. It gets more complicated though when a dermatologist actually sees you and says they diagnose Maya with something called atopic dermatitis. If they fail other treatments that are more conservative, sometimes I recommend something a more aggressive treatment. And so Dupixent is something that I've seen prescribed to patients that have really serious dermatitis of this form. That's usually an autoimmune disorder. It's actually quite an expensive drug, but it's very effective. Made by Sanofi, a big drug company. And the only reason I wanted to highlight this particular point in the care journey is that you may, as a patient, actually go through many rounds of treatment before actually landing on a successful treatment. Usually, that requires a specialist to actually refer you to this very specialized treatment, and ultimately that costs money. And it's in this case a very expensive drug. We'll talk a little bit about how insurance is factored into this. Ultimately, in this case for Maya, thankfully her insurance covered it all. And we'll explain in the next two slides kind of how that happens. But just wanted to paint this general picture of like, a lot of you folks kind of see doctors, hopefully at least a primary care visit, if not some specialist. If you get to a point where you're seeing a specialist multiple times and we're trying multiple things, healthcare can progress to a certain level where you need help. You need a specific, in this case, a biologic injectable drug, kind of like insulin. If anybody's familiar with insulin, it's very similar on how you administer it. But that is something that happens not uncommonly in healthcare when first or second line treatments fail and we have to go to a more aggressive treatment. I wanted to highlight this mainly because it starts to paint the picture of what I want you guys mainly to take away from this talk is that it's not just the patients in healthcare or even doctors like myself. There's a whole lot of other stakeholders that are really important to understand in healthcare, and they all work together. So in this case, Maya's the patient. Her parents have an employer. For example, a lot of your parents may work for companies that ultimately fund your insurance when you go to college or even up until you're 26, in most cases in the US. The provider, the primary care physician or the dermatologist that saw her and treated her would be the third stakeholder. And ultimately, the insurer, for example, Blue Cross Blue Shield, Aetna, whatever insurance company you may be familiar with, they are the people who actually finance, who pays for the doctor's visit, and ultimately who pays for the drug. And they also get to decide how much coverage you get for both the doctor's visits and the drug visit and actual drug. And ultimately, in this case, Sanofi in particular is who manufactures Dupixent, that drug that I had mentioned. They may offer assistance as well. If they really want patients to get on that drug to improve access, they'll offer things like copay cards. And so basically every stakeholder in this diagram, I would say, is optimizing for different things, right? The patient obviously wants fastest, most effective treatment. The provider wants to see as many patients as possible and to treat as many people as we can. And ultimately to see people that are within our scope, right? So a PCP, a private care doctor, cannot prescribe Dupixent that's outside of their scope. That's why that referral pathway exists. That's why specialties in medicine exist. Payment in at least the US is quite complicated because there's this middleman person between an employer and also payer, and sometimes they act together, and sometimes they have very different incentives. For example, you might imagine in another universe, maybe the payer does not want to approve Dupixent, right? Because it's too expensive. They don't think it's actually, they didn't see Maya try other therapies before getting all the way to the expensive drug. And so they may deny, for example, that prior authorization. And then that would kick off another sort of set of motions that maybe would cause Maya some frustration and ultimately going back and forth. And so it's not usually this clean, but I think I wanted to just show you guys a broad snapshot of how they all work together to get Maya the treatment that she needs. Okay. And this is one very kind of back of the envelope example. You may be surprised, actually, a lot of drugs are actually quite expensive, and we're not actually paying thousands and thousands of dollars for every drug that we use in the hospital or even in the outpatient setting and where you folks see clinic doctors. Because of something called deductibles and out-of-pocket maxes. Okay, this is very common in the insurance world, where the insurance may want the patient to pay a certain amount, but after a certain maximum, they take over all of the costs completely. Okay. And this is important because when you talk about access to healthcare, access to drugs, access to even seeing doctors, it's these numbers that matter a lot. And these are also, unfortunately, sometimes what bankrupt patients when they accrue medical bills they can't pay for. And I see it a lot, unfortunately, in my world as an emergency doctor because we can't predict the amount of treatment or the amount of care that a patient might need, and we're not actually allowed to ask for insurance upfront as providers. It would, for that to guide our care because that would be, inequitable, right? And so I don't care exactly. I don't care at all actually what insurance a patient has, but I know it greatly impacts kind of what financial costs they bear when they leave the hospital after they've seen me, unfortunately. Yeah, I just mentioned this because when you talk to patients, when you yourself are seeing doctors, you'll be thrown some of these terms. A deductible is what you normally pay before insurance helps at all. Sometimes there's high deductible health plans, in which case the number is much higher. And then most plans in the US at least have an out-of-pocket maximum, which is a number that if you hit it, for example, my parents, it's kind of in the tens of thousands. Then the insurance will cover the rest of that. But they are responsible for up to that amount. Okay. Really important in this slide, I think I just wanted to emphasize the person who's using, in the case of the patient, is almost never, at least in the United States healthcare, the person's paying for treatment. Okay. A lot of this payment happens behind closed doors, behind the pharmaceutical companies, behind these entities called pharmacy benefit managers like CVS Caremark or Express Scripts. These are large healthcare institutions in our country that frankly make healthcare a little complicated, but ultimately, I would say, as a net positive, improves access for everybody because you wouldn't be you wouldn't want to pay $36,000 if this is a life-saving drug for you. You would hopefully not have to pay anything, right? And this is the case of Maya in particular, that her case with the copay card and the insurance sort of benefit that she has access to. Okay, so take a quick look at the chat. Great ideas coming through. I'm going to go through just two more examples. So I just want to give you guys a couple of more context before kind of diving into some of your great ideas. You might ask, why does insurance exist? It actually, in most countries that have maybe single payer healthcare, insurance is actually not this complicated. It was kind of a byproduct in the 40s when World War II wages were frozen across the country. And so employers, for example, like Coca-Cola, Intel, and some of these large companies that existed for maybe a while, they started to offer what's called fringe benefits, healthcare benefits, as a way to differentiate on top of the salary because all the salaries were frozen and equal. Those were ruled as being tax exempt, and so basically these fringe benefits, these insurance products, stuck around. And companies actually ended up forming around them. The first one being Blue Cross Blue Shield, which you may be familiar as a big insurance company. They have state-sponsored plans in almost every single state. And that kind of started becoming the norm. So much so that in the 60s, Congress created basically Medicare and Medicaid, which are federally funded or state-funded insurance entities, which cover kind of different populations, which I'll talk about. But that was a catch-all for everybody who wasn't on an employer-sponsored plan. They would fall potentially eligible for Medicare or Medicaid. And then in the 2000s, kind of Obamacare came out, which made it even more accessible for people to afford healthcare because there was still a gap, actually, because in the case that you made too much money, for example, for Medicaid, but you're not enough to have a good employer-sponsored health insurance. It's a big insurance gap. And this still exists actually in our country today. It's actually gotten a little bit worse. But there are subsidies through the Affordable Care Act that kind of allow for people to afford insurance. And why is this so important? A lot of folks that I've noticed in the chat you're tackling some really serious health conditions. that ultimately will require payment and require doctors to be seen and drugs to be prescribed and access to be figured out. A lot of, in this country, sadly, the problems that plague our healthcare system are around cost, unfortunately, affordability, and what type of insurance plan people are on. And so I think as you guys get deeper into the healthcare space, you'll start to come up against these entities more and more. And so understanding kind of where it comes from, what Medicare is, how that different from Medicaid, these are all kind of important concepts to eventually understand. Okay. Really quickly on Medicare versus Medicaid, you'll hear these terms thrown around a lot. Your parents, if they are over 65, are likely on some form of Medicare. This is probably the best type of insurance we have in our country. It's federally sponsored. You qualify through your age if you're over 65, or if you're disabled, if you have some type of disability, either medical or another type of disability, and they'll cover everything from hospital stays, outpatient care, prescription drugs, and there's even a private plan option called Medicare Advantage if you opt for that. Medicaid is a topic of great consternation in our country. It's funded both by federal and state governments, and it varies widely, I would say, based on the state that you're in, how Medicaid is adjudicated. Okay. And so I don't think anybody's kind of directly going after that, but it's a big passion area of mine because I care a lot about serving uninsured patients and low income patients when they come into my emergency department. And so I deal with Medicaid a lot professionally. Um, this is another care journey. I just wanted to give you guys a couple of other kind of wrinkles here. This is Marco, who was playing a soccer game over the weekend and ended up tearing his ACL through like a tackle slide, a really nasty sort of knee injury, which I see not infrequently. And so he was actually transported to the emergency department to see a physician like myself via ambulance. 911 was called. And in his case, the emergency department he went to was in network, but the group that staffs the emergency department may not be. And in his case, he's on what's called a PPO, a preferred provider plan. And so if the provider is not within that preferred group, it actually bumps up his financial obligation because there's certain facility fees, professional fees attached to that visit. So a lot of patients are not aware of that when they come see us in the ED, that the department is sometimes separate from the people that staff it. And so just another wrinkle in our healthcare system, sadly, that is, creates a little bit more complexity. I'll breeze through the rest just to kind of like maybe get to the meat of kind of giving you guys some feedback. But in this case, he needed surgery. Prior auth needed to happen before insurance approved that surgery. I think he was stay actually in the hospital. He was admitted from the emergency department into the hospital, and he was receiving a couple of different types of bills. One from the hospital, a facility fee, one from the surgeon that did surgery, and another one from the anesthesiologist. And then ultimately, he couldn't walk actually after his surgery, so he needed outpatient physical therapy to be approved. And so that was ended up being part of his care journey as well. Ultimately, even for something that is an emergency, an accident, this probably would cost Marco, even if he was on a pretty good insurance plan, I would say probably anywhere from a couple thousand to tens of thousands of dollars, unfortunately, because um, none of these things are completely covered by most insurance companies. Even emergencies, unfortunately, have some out-of-pocket costs. Surgeries, especially if you can't choose where you do your surgery, some only parts of it will be covered. And even things like rehab, unfortunately, is not fully covered sometimes by insurance companies. And so just wanted to give you guys a sense that, it's not as simple as just seeing a doctor, getting a nice clean physical exam and walking out of there. Sometimes even accidents happen and you end up stuck with a pretty hefty bill. And these are all the stakeholders, again, the cost payers, providers, insurance, pharmaceutical companies that all kind of are working behind the scenes to help Marco receive the care he needs. This is a bit complicated, so I'll just kind of highlight a couple of things. This is in the case of some of you folks are working on ideas involving caregivers. For example, people that are taking care of the true patient. So in this case, this 83-year-old patient, Noor, the main kind of person taking care of her is her daughter, Fatima. And so in this case, the only thing I wanted to highlight is that sometimes diagnoses go missed or delayed for many years. In this case, Alzheimer's, which is a neuropsychiatric disease, is a neurocognitive disease. It's actually a very tricky diagnosis to make and requires actually an area of time for physicians to feel comfortable diagnosing it. There's a lot of what's called generic drugs, which are not specialty drugs or branded drugs that are approved for Alzheimer's treatment. And so very often those are started first, but sometimes those don't work. Like in the case of Dupixent earlier for atopic dermatitis. And so in this case, she needed a neurologist to go through some of those options before something like Leqembi, which is a very new sort of treatment, new FDA-approved drug for Alzheimer's, is offered to her mother-in-law. But even despite treatment, for example, and her mother may need more care than Fatima at home can actually provide. And so, unfortunately, she'll need to stay in what's called a skilled nursing facility to get more nursing support. And in order to qualify for that, you actually have to be admitted to the hospital, stay at least 3 days for Medicare to actually qualify you to go to a skilled nursing facility. Okay. And even after that, if that care is not enough, or again, her memory issues decline, Nora's memory issues decline to a point where she needs more additive care, they may get recommended to go to a memory care facility, in which case, that will have to be again approved by insurance, unfortunately, and doctors will have to kind of advocate for Nora that this type of medical support is needed. But the only reason I highlight this particular journey is that oftentimes patients in their most vulnerable state, they can't actually fend for themselves. So hopefully they have family members or daughters in this case to advocate for patients, but sometimes they don't. And there's different agents in the system, for example, case managers, social workers, even physicians like myself, that will do our best to advocate for patients. But there's a lot of gaps in our healthcare system, and unfortunately, patients sometimes fall through. And so these are other kind of problems that you guys may consider as you kind of think about things to work on this summer. Um, just to paint a picture of the world that I see, I'm a AI researcher by background. I think a lot about building things in healthcare as an investor, an innovator, even though I work in the traditional kind of old model of healthcare that is kind of broken today. These are some examples of things that I think can improve patient experience and ultimately extend access and affordability using some of the new technologies around AI that are coming out, for example. So one big, I think, trend that I see that's emerging is that rather than just seeing a doctor when things are wrong or when you're symptomatic, really trying to think about predicting symptoms before they happen and trying to what's called risk stratify patients so that you're actually proactively, before you even end up in the emergency department or in some kind of clinic, you're proactively using technology to triage how urgent a patient is, how urgently they need to see a physician. Rather than just the four walls of a doctor's office where you consider healthcare being administered, you can think about healthcare inside the home with all these monitors that are going on, right? People wear Apple Watches. People now have remote sort of SpO2 monitors and measure their oxygen. There's all these sort of devices that are now allow healthcare providers like myself to see how patients are doing from the comfort of their own home. And so this really extends the four walls of the hospital, the clinic where we traditionally work, into what we call remote patient monitoring. This is a big trend that's happening right now. I think a lot about our aging population in the United States, people that are having, like I said, memory issues or cognitive issues. A big epidemic in this country is frankly loneliness. That are left to fend fighting these diseases by themselves, and so things like AI companions are helping automate some of these really challenging sort of medication sort of scheduling for these patients. These can all be helpful for patients kind of in their most vulnerable states. And ultimately, I just think there's a lot of things that are happening right now where people are actually using ChatGPT or Claude to basically decode why our healthcare system is so complicated. I see a lot of patients that walk into my emergency department that have actually just typed up all their symptoms to ChatGPT and just given them kind of like a help prep them essentially to see me. And it makes the appointment sometimes go a little bit more efficiently. Sometimes they help decode things that are not obvious to patients, or decode even things like financial complexity when they get like a really hard to understand bill. Some of these technologies can be really helpful in being kind of a co-pilot for these caregivers or patients. Okay. Um, and then I won't spend too much time on this, but there's a lot of friction, I would say. You heard me mention multiple times this topic of prior authorization between providers and payers. And this is a super unique thing of US healthcare where this entity of payers even exists. And so, as you guys get deeper into these things, you see things like administrative sort of issues, or when your parents are faced with healthcare bills that they don't understand, or they're getting denial flags. These things are problems that you can work on and try to solve with technologies. For example, using AI to assist prior auth approval, trying to advocate for patients by drafting, for example, provider letters of support to approve certain things. These can all be sort of things to help us as providers so that we can spend more time working on patients, advocating for patients and ultimately helping patients, kind of navigate the healthcare system more effectively. So I'll just end on this slide. Again, just highlighting these five stakeholders. Again, patients, providers, payers, pharma, employer. I would encourage actually for every single one of your ideas, you should really be engaging with at least two or three stakeholders. So we kind of have like a holistic approach around your idea, and I'll challenge some of you to do that as we're kind of as I'm giving feedback to each of your ideas, because I think that really flushes out um, why is it so challenging to tackle certain healthcare problems? It's usually because these stakeholders are not super aligned or working together. And so making sure your solution is creating value or improving sort of some sort of friction for one of these stakeholders or ideally multiple stakeholders that will allow you to have a much stronger idea and ultimately help build a more, let's say, efficacious, accessible healthcare system, which we all need. Okay. So with that, maybe um, I will take a couple of these ideas. Actually, maybe I'll just pause if any, if we have a small enough group. If anyone wants to ask any questions live, I'm happy to answer them about any topics that I covered. And if not, I'll just go down the line and let's give you guys some feedback live and based on your ideas.
Yeah, that sounds great. Thank you, Sherman, so much.
I guess I have one general question.
Sure.
Um, yeah, you touched on the stakeholders and how it's kind of important to look at I guess, the problem holistically.
Mhm.
Um, but like given that we only have 4 weeks, I'm wondering how is it that we can keep this in mind and also kind of account for the holistic, end-to-end
Yeah,
Yeah,
kind of
actually,
yeah,
maybe if I could
great.
expand on that, Sherman, for
Go
everybody.
ahead.
Public healthcare data a lot of times is very personal, private, sensitive, regulated, and so any tips in general for building in this, both in the question that was just asked, like how can we kind of keep this all this stuff in mind, and tips for getting started on a kind of prototype or starter project, or what's possible in a short time. I think maybe you're muted, Sherman. Go ahead.
I think the only thing I would add is, yeah, again, like it's only 4 weeks. I wouldn't imagine that you guys have like a fully fleshed out solution for all stakeholders, but I think just understanding why are these problems in the first place, right? Somebody in the chat is tackling like stroke areas where people are underinsured or uninsured. Why is that even a problem in the first place? Because of this kind of fragmentation, this stakeholder misalignment. And so understanding kind of where these problems are rooted for may give you some more insight on how to solve them. But no, I think for the purposes of these 4 weeks, I think if you can put together a prototype of some sort that's demoable, build something, I think that can be helpful. But I mentioned this because sometimes people are just looking for things to solve. I would say any solution that reduces friction across the stakeholders is a worthy problem. Happy to take other questions. If not, there's a lot of great ideas in here. I'd love to give just some feedback to folks. So maybe starting with Winnie, I see you guys going after health, I'm assuming misinformation on social media, got health supplements. Um, is there anything else you wanted to add, Winnie, or things you wanted specific feedback off? If not, I'm happy to just give you some general pointers as you go after that idea.
I think
Um,
Nina, because I'm working with my peer Nina. She's the person that's more on the technical side, and I'm the
great.
person that's more on the health side. So
Okay.
Nina, if you have any questions about the technical side, you can ask. She's also in this Zoom right now.
Okay.
Oh, yeah. I mean, I guess I guess like where we're at is like we've been talking and I think we've identified like a loop where the core problem is in terms of misinformation. It's less tech and more like industry oriented, to be honest, but
Mhm.
we've seen that on social media. There's a lot of influencers, but even like
Yeah.
people who pose as health professionals stating claims about gut health
Yeah.
supplements that aren't necessarily true. And so we wanted to kind of introduce AI to basically like kind of more clearly and like frictionlessly break down these claims and kind of score them based on like how true they are, given like maybe a a subset of sources that are government backed or research backed or whatever, like by academia. But, you know, someone pointed out that, AI can also bring out misinformation. And then we also looked at a tool
Certainly.
called Retraction Watch, which where like academic and science papers are being retracted kind of like continuously. And so I guess it's just more like how do we look at that problem? And then, sorry, like another facet that we learned about today is that it's very unlikely that we're going to be able to like flag misinformation on TikTok unless we work there. So like how can we leverage a tool
Mhm.
to do something else? And one of the research sources said that um, you know, combating this with like more videos isn't necessarily helpful
Mhm.
because it just adds confusion to like the dialogue. And so
Mhm.
maybe there's a way to like have doctors partner with the tool or something like that where like instead of like every doctor becoming an influencer, maybe they're like actually like feeding into this tool and like making it richer or more accurate or
Yeah.
something.
Yeah.
So yeah, there's like a space for doctors to be more, I guess,
Okay.
involved with the general population with outside of just like an appointment, I guess.
Yeah.
And
I love that. Couple of thoughts. I would say I'll give you two perspectives. One as a former hacker myself, I think easier probably to actually collect audio actually from videos and just try to get a sense for like what are the phrases or key medical terms that some influencer is saying, and maybe look up fire off like an asynchronous call to like some PubMed API, just trying to get a sense for are there like reputable articles that are cited, well resourced by reputable institutions, and just developing some type of validity score against that. That can be one way of kind of going after veracity of claims. But I agree, I wouldn't necessarily go after video. I think that's probably a little too heavy-handed to try to synthesize video into concepts. Audio is probably good enough. With my physician hat on, I would say a couple of things. I've definitely noticed this trend myself. I work in Palo Alto where I have a lot of very tech affluent and tech native sort of patients that come to me that claim a lot of things that they do a lot of myth busting and dispelling. I would say we're pretty burnt out around this particular problem, and I would probably caution you away from trying to build something that employs physicians to be more of the screen. I really want you to think about the incentive. Like, why would a physician want to do more screening, more filtering? Is there a financial incentive to do so, or do you just want to help more patients? Like, I struggle to kind of think about what the value adds to that stakeholder in the healthcare piece would be. Um, but I think the other way you could look at it is like I said earlier, just like trying to help the patient prepare for an eventual doctor's visit. For example, if they're trying to see a GI doctor, basically reframing the whole care journey in a helpful sort of report, so that the first interaction with the GI doctor is productive. You know, and it's not sort of like all these claims back and forth in this very fragmented way. Like it makes sense to a provider. It's ordered in a certain way. It's triggered by certain like foods, for example. But like I have a clean sort of sense of why and what the problem is when I see a patient, rather than like a discombobulated sense of thought. And so maybe that I think the product, on one hand, is just veracity and checking kind of like validity of the claims that the source is making. On the other hand, for providers, it could be as useful as just like a prep sort of like report that they can bring with them to their first visit. Um, I want to move on to Kathleen. I think you have a really interesting idea. I don't know if you want to expand on insurance coverage as available for access to stroke care. I think a lot about this because I work at a comprehensive stroke center and I receive a lot of patients that are in underserved areas. So I'd be curious, Kathleen, what you're thinking about around this idea.
Yeah, I can explain it a little bit more. So, basically our idea right now is like we're gonna create two scores. One of them is like a stroke vulnerability index, and then the other one is a stroke care access index. And we're just
Mhm.
looking at like New Jersey, New York, and Connecticut. And like based on those two scores, we're gonna try to look at like which areas are at the highest risk, like in combination of both
Mhm.
being vulnerable to getting strokes and having the lowest index. And then like our like plan for the deliverable, I guess, is to like we're trying to do like a website with maybe like a heat map of the
Mhm.
tri-state area. And then I think like a question that I have that like, like relates to the topic we're discussing is for our like accessibility index. So I mentioned that we are including insurance coverage. I think we're doing hospitals per capita, hospital beds per capita, physicians per capita. Is there anything else that you would advise us to like look into in terms of accessibility?
Yeah, I would say, as you guys have probably gone into, like the capabilities of the stroke center is really important, right? Whether they have a teleneurologist or what's called an interventional radiologist that can like remove a clot, that changes the stroke sort of comprehensiveness drastically. I think it's like level 4 versus level 3. I forget the exact terms, Kathleen. But understanding kind of like what that mapping area. The other layer I would add, just because I experience a lot, it's like in strokes, time is brain. And so even something like even a barrier around like how long does it take for a paramedic to get out to a certain zip code is important, right? And so how many ambulances do they have in that county? What's the average response time? How much ground do they have to cover? Sometimes it's maybe actually kind of hard to look up there, but should be at least federally published average response times for at least the Medicare patients. And so you can look up stuff like that, Kathleen, that's kind of like kind of better shape and kind of heat map some of these areas that are, I would say, like a clinical desert when it comes to receiving comprehensive stroke care. I wouldn't be surprised actually if a large portion of the tri-state area is actually not covered by a comprehensive stroke center, and it's only available for people that receive a medicine called TPA, which is not exactly clot removal technology. And so I would just, as we go deeper into that space, Kathleen, just like remember what I told you, like interventional radiologists and teleneurologists can be very different things. And if you have what's called a ischemic stroke that's caused by a clot, that can only be removed by interventional neurologist or vascular neurologist. That's a procedure and it's not a medicine. And so if you have one of those strokes that you find on CT, they have to get to a comprehensive stroke center and then so understanding that from the paramedic perspective, from the patient perspective, can be very challenging. You're not going to know until you get the imaging, unfortunately.
Uh,
Okay, thank you.
Hey Sherman, your audio is getting a little like blah, blah, blah. So it might be
Oh,
your battery is getting, or you need to readjust a little there. I just don't want people to feel that. We could hear you, but it's like
okay.
it's
Okay.
degrading.
Thanks,
Yeah, that's
Kat.
bad.
For
Yeah,
that.
great. Great.
Okay. Um, I had some questions for Nick. I'm going to let you respond in the chat so I can move on to other ideas. I'm not really sure what signals or quantum NLP mean. Nina, it's the same idea that we talked on earlier. Mercedes, you have a pretty cool idea around skincare routines. Oh, very cool. Yeah, this is very relevant. Um, I have a lot of thoughts on this actually, because I myself have looked at a couple of telederm companies with my venture capital hat on. But Mercedes, you want to add any color of what you need the most help with around this idea?
Yeah, and for people watching the recording, they won't probably see the chat. So if you just share a little bit out loud so people know what you're talking about.
Yeah, sure. So basically right now, like this is just like the backbone idea you would say. I'm kind of just like still trying to like narrow down like what exactly like in the skincare sector I want to focus on because I feel like it's too broad and I don't know if I should focus on like for example, like maybe acne or stuff like that or if I should just like
Hmm.
keep it very general if that makes sense. That was one of the concerns I have and the other concern I had was like, I'm just kind of not sure if it would be maybe like people take a screenshot of it and then maybe like put it in
Hmm.
like the website or if it would be like a link of some sort. I'm still kind of like trying to figure out which
Yeah.
would be the best approach.
Yeah, a couple of thoughts. Again, with my hacker hat on, I would say easiest prototype to build for you would probably be just taking a picture of the back of a label for one of these routines and having them pick. Well, I would start by just getting image capture kind of fidelity, just capturing single images of each skincare product and then kind of loading them up as a routine, maybe no max of like 5 or something, and just trying to tease out, the active ingredients from each of those images and seeing how it maps to maybe a skincare routine. Is it a moisturizer? Is it like a cleanser? So on and so forth, and trying to see kind of what active ingredients are present and what are missing. I think more important, Mercedes, I would spend at least some amount of time, and you can, if you don't have any, let's see how the best give you advice here. Um, there are some great dermatology journals. I would just look up like dermatology medical journals and like what are clinically efficacious skincare routines, right? Because I don't want you to get dissuaded as a clinician by all these kind of things that are posted in blogs and whatnot that are like, maybe not scientifically accurate. So I would encourage you, at least as a practicing physician, to try to align your tool to dermatology gold standards, which are published. I don't have, try to get in touch with the dermatologist to student and working in the program. Or talk from Dr. Leung, and he recommended I reach out. So you can use my name or whatever. But yeah, try to just get a little bit more scientific guidance, sort of description of what is actually like efficacious skincare. And then through your solution, you can try to match and see if there's any kind of key active ingredients that are missing in the routine and start to recommend products would kind of like, fill in the void, right? So, what I would say the version 2 of your MVP, after you kind of get to active ingredient scraping and understanding kind of what step in the skincare routine it matches up to, then you can start to make recommendations like, oh, you're missing, I don't know, like the moisturizer step, or I don't know, the exfoliation step. And actually, here is a product that I would recommend for you because it's missing from your skincare routine. And you can buy it here from Amazon, and you can maybe go attach an affiliate link for your case and actually make a little bit of money doing that. But yeah, no, this is a great idea. I think I would push you to think about the easiest thing to build, which is just getting ingredients off of the label. Step 2 is like mapping it to an actual routine, of which I would really encourage you to understand what a good efficacious routine looks like. Step 3 would be starting to make recommendations using AI to actually help patients with skincare.
Okay, thank you.
Yeah, thanks, Sherman. Your audio is still a little bit in and out. I don't know if you want to try one more thing. We can keep going, but it might. Yeah.
Okay, I'll use my laptop.
There was one part where you were saying like, "Hey, and tell them, I sent you," and I want to make sure that people can hear stuff like that. So you drop my name if you need to. Thanks.
For our uses question, a lot of these ideas, I would really reflect on 2 things. As a patient yourself, maybe, or at least you've seen as somebody go through the healthcare system. The question was around like what do we build in? A lot of medical models are not public. We can't really access them. You may have seen actually there was a recent Nature article published, and that's been making a lot of splash that some of the generic large language models have been proven to be just as good as some of the proprietary medical models. So actually, for me as an investor, I actually think the technology is not super important, like how high fidelity the model is to go after problems. I care a lot more about the problem that you go after solving and what sort of inefficiency you're trying to solve in the healthcare space rather than technology you're building with. Okay. And so I would really encourage you to reflect on the frustrations you might have had as a patient or somebody watching a loved one go through the healthcare journey. What problems do they have as they go through? What seems inefficient? And really think about, are there opportunities to make that a little bit less painful? So I'm happy to share slides. I'll do that link actually right now. So my talk, I listed a couple of areas which you could actually investigate yourself, but things like a caregiver co-pilot, something to help with prior authorization. These are all kind of areas that I would encourage you guys to go after.
Yeah, thanks, Sherman. What's the biggest mistake you see when you're in your like VC life when you're evaluating healthcare potential businesses? What's the biggest mistake people are making that you could help folks avoid?
I would say I want you guys to have a build first attitude. I certainly did when I was an engineer and building things as a CS student. As I got deeper into healthcare, I realized this is kind of the root of my talk that you can build really cool things, but if people don't use them or they're not incentivized to use them, you're not actually solving a real problem. And that's what I've seen time and time after again by well-intentioned founders that I meet as an investor and also by other people that walk up to me and ask like, "Hey, would you use this for a provider?" And if they don't understand the workflow or some of the challenges in our healthcare system, sometimes it's actually creating more complexity to the already complex healthcare system. And so, I think that's really important to understand, like, where does your problem sit? In this kind of vast array of healthcare inefficiencies and misalignments of stakeholders, and just go through that exercise like I taught you, like who's the patient, who's the provider, what do they care about, why would they be incentivized to use this solution, and that will get you, I would say, 80% of the way there if you continue to ask why multiple times, why this person is incentivized to do this or X or Y.
Yeah, that's great. That's really helpful. It's like do start building things, but then put it in front of someone early enough that they
Yeah.
can say if it's useful for them or not. I saw a great talk, DJ Patil, our great leader here, and Bob Wachter, where they were talking about Bob Wachter is saying in the UCSF, where he is in the medical system, people are often coming in trying to sell him things that will replace doctors, and
Yeah.
that's like not a great pitch for him.
Yeah, and some things probably are automatable. Like I don't want to do everything that I have to
Right,
do in
yeah.
the emergency department, but you're not going to replace me if I'm out there treating patients and I understand nuance that AI will not understand. And so just make sure that what you're pitching and the kind of solution you're building, you design it with the existing stakeholders in mind. Um, I want to understand Nick's question a little bit better. Do you want to come on live and just ask Nick what specific question you have that I can help you with?
Yeah, sure. Just I'm not coming from a medical space, but I've made this quantum technology that or algorithm that can be trained on benign physiology, and it could detect uh, di- problematic diagnoses that classical cannot, because it just looks at individual ailments that seem benign, but a supervised doctor or physician might say that when they're combined, that they are actually diagnosed as problematic. So I'm just curious if there's other domains I should look at that has this type of characteristic.
I'm not really sure what would be the input to your solution.
The input? What do you mean
Input
by
and output. Like I'm just trying to understand like what are you plugging into your tech and what's coming out.
so? Think of it like this started with zero-day malware detection. So the input was API documentation, which is
Okay.
proper usage,
Okay.
and then it was tested against labeled malware
Okay.
without being trained as such, and it my quantum algorithm detected less false negatives than current
Okay.
online
So
code.
you're asking me like what sort of healthcare problems you could point this technology at?
Right.
Okay. Um, I think this part of the issue, Nick, I'll be honest, is like it's really challenging to get like good healthcare data that you can actually run algorithms with. I think the best advice I can give you is trying to find synthesized healthcare data sets that are out there. Some of them are actually publicly available online that look pretty realistic. They're not, you're not going to be able to get like real healthcare data. I'm just going to be frank with you. So
Mm-hmm.
to be able to have like signal versus noise sort of algorithms is super challenging. So you can go after synthesized data sets. There's public Medicare data sets that are purely financial claims data, and you can try to get a sense for like, are these overinflated bills? Are they maybe even fraudulent Medicare bills versus like, things that are actually within scope, and try to develop like a variance between what seems like in scope, like normal range for a certain type of medical condition? That would be kind of one sort of area. But I'll be honest, Nick, I've worked in this industry for about 10 years. Our data is very messy. It's not as clean as API documentation. It's going to be very challenging. You'll probably have to rejigger a lot of your algorithm. And so gets to my root of like, people build a lot of cool tech and they bring a lot of cool tech to healthcare, but a lot of times incentives cause, solutions to be really challenging. In this case, it's not really a data problem. It's like a sparsity and accuracy of data problem. So if you're gonna have poor inputs into your algorithm, Nick, there's not gonna be great output at the end, is what I'm trying to say.
Yeah. I've looked at ClinVar and some others, EEG, epilepsy. That's what I've cited. I'm just curious what specific medical field. That was my question, not what data source.
Oh, I see. Yeah, EEG data is helpful if you're going to be doing signal to noise for like seizure detection, I'd say. But that is a pretty well-bounded clinical problem. I would say like it's not like a really inefficient process right now, in my opinion. Um, I would encourage you to think more about more subjective type of studies, like trying to think of a good area to point you to. Like EKG analysis actually is something you could think about. There's this guy Pierre Elias published a study in this space that you can look up. He's done a lot of good AI work in that space. Yeah, cool.
Thank you.
Yeah. Anybody else who I didn't get a chance to comment on? I've got 5 more minutes here. These are all strong ideas so far. Oh, I missed McKinley's idea, I believe. Did I miss McKinley's idea? Food allergies. McKinley, did you want to ask any questions about your idea?
I would just like to ask more of like a question on balancing my storytelling, like my personal
Mm,
storytelling with research credibility,
okay.
as it relates to like allergy research and new technologies out there, if that makes sense.
I think if you have allergy, like a background in allergy, you should totally leverage that. I don't know what
Okay.
else to say, McKinley. I don't know much about your background. I'm sorry. And yeah, I'm not sure what your question is actually.
Oh, I was just asking, so my main project is a website exploring
Hmm.
my life with severe food allergies and
Mm,
like the science and treatments and policy questions surrounding them.
hmm.
With new technologies like AlphaFold, I don't know if you know what that is, but
No,
it's an AI system built by Google DeepMind that can
cool.
predict like the 3D structure of protein from its amino acids. Um, so yeah, I was thinking that that would help find a cure for my allergens. And maybe there's other technologies out there like that. And this is supposed to be a foundation for my senior thesis.
Great.
So
Um,
yeah.
Yeah, I would say, I mean, a lot of Dupixent is one such recent biologic that's come out for people that have really severe atopic dermatitis and certain allergies that are considered autoimmune. And so if you're getting at like, how do we develop more biologics like that using, AI-enabled sort of biomarker discovery, structural biology sort of targets, I definitely agree. I was a structural biologist myself actually in high school, and I discovered things that led to RSV vaccine and those things. So I definitely believe in the technology to allow for more high throughput screening. I think in your case, the challenge is going to be linking um, kind of like the existing therapeutics out there and what's like still missing. For example, are there certain like biomarkers or proteins, for example, certain amino complement sort of like targets that have not been really targeted yet. And those could be like new opportunities for biologics. That could be like one area. But even just as simple McKinley as mapping out like what are all the existing strategies that have been tried so far for allergy treatments, and what is still technically white space, and giving people like yourself, like patients like yourself, like hope, and that like there are still things that are there's still white space out there, and here are kind of like marquee projects or landmark clinical trials that are in those spaces. That would be how I would kind of paint your space.
Thank you so much.
Great. Awesome, folks. Well, I believe I have some mentoring hours available. Kathy, you may know better than I what when those are.
We're still our little mice are turning in the wheels over here
Okay,
trying to get
great.
everybody
But
scheduled.
yeah, feel
But
free
yeah,
to
are you on Discord too, Sherman? I forget if you joined.
I am not.
Okay. Want to, it's pretty fun. You should join.
Okay.
But definitely, if not, what's the best way for people to get in touch with you?
Yeah, I would say email is probably the best way. You can email me Sherman Leung md@gmail.com. I'll just put in the chat here.
Great. I'll put it in the chat here. Yeah, there it is. And if I'll just share it with everybody. Thank you so much, Sherman, for your time. Thanks for all going through
Oh,
all these different project ideas, giving people some kind of direction here as everybody's trying to focus in, and hopefully it's helpful for the folks who are here, and hopefully helpful for folks who are watching this later on the recording and can think about these different pieces of the patients, the doctors, the systems that people are in as they think about how to improve some of those things. So thanks again for your time. Really appreciate
of
it.
course.
And
Yeah.
have a good rest of your day.
Thank you. Great
Yeah,
to see
thanks,
everyone.
everybody.
All right. See ya.